Hi everyone, we're gonna get started. So my name is Charlie Zhao, and I'm one of the residents, and I have the distinct pleasure of introducing Dr. Michael Schwarzschild. So a little bit about him. He is a professor of neurology at Harvard Medical School and a director of the Molecular Neurobiology Lab at the Mass General Institute for Neurodegenerative Disease. After doctoral training in the enzymology and pharmacology of dopamine, Dr. Schwarzschild joined the MGH Neurology Department initially as a resident, followed by a movement disorders fellowship under Eng Yang and John Grouden. He then joined the MGH faculty and developed a translational research program focusing on the role of purines, adenosine, caffeine, and urate among environmental and genetic influences in lab models and clinical studies of Parkinson's. His group in the Mass General Institute for Neurodegenerative Disease conducts interdisciplinary studies spanning the basic, epidemiological, and clinical science of Parkinson's. From 2012 to 2024, he led the Parkinson's Study Group consortium of North American clinical trial sites and investigators dedicated to finding improved treatments for people with Parkinson's. He also serves as a clinician in the MGH disorders group caring for patients with Parkinson's disease. Please join me in welcoming Dr. Schwarzschild.
Thank you. Thank you, Charlie. Um, Happy Halloween. Um, I'm going to present on the rather grand but now wonderfully plausible idea of preventing Parkinson's disease. The work I'll go over spans work across the research community with our lab and group based in the Charlestown Navy Yard campus, which is connected to here by the Zakim Bridge, which over the years we've adopted as a metaphor for the translational work that we do with the help of a local artist, Don Isles. And the translational themes that I'll cover most obviously is the value of prevention. Other translational points that hopefully I'll be highlighting are the fruitfulness of working across disciplines. For me, it was bridging my own background in neurobiology and my training here in clinical neurology with epidemiology, working with Alberto Esquerio at the Harvard School of Public Health and his insights into Parkinson's disease. And then also in this translational journey, the great value and fun of working with the families, whether it's the neurology family here or one at home, which our former chair, Ann Young, here, if you look in the lower right corners, just 30 years ago, now at the end of my residency, highlighted as she's customarily done with a drawing, in this case, noting my affection for the basal ganglia and how I tried to stitch it together with my own hobby of sewing, which she had known was probably my greatest accomplishment in terms of designing anything, which was, although this was actually a very easy Vogue pattern. So, but I did stitch it together. This is just before the residency, reflecting the preclinical work as well. And then that family feeling here, just from an old photo here, highlighting the blending of home family and the department here in our residency group, which was smaller back then when it was just 5 adult neurologists here on the Mass General side, including our leaders in the department, Tracy and Merritt, but also to pediatric neurologists, Marcio and Tali, and our senior residents, still represented so nicely by Steve Greenberg, still reflecting the friendship and mentorship that we've had all along. And Betsy and I, we made the first contribution to the next generation during our residency. This is our daughter, Sarah, in the middle. Not to overly suggest the co-parenting from fellow residents of Mike Irizarry and Merritt, and now 30 years later with our family extended with Sarah's having delivered granddaughter, Frankie, for us. But back to more traditional educational goals. What I'll try to cover here are three. The first couple are pretty easy to highlight Parkinson's disease treatment types, and then go over stages, and then talk about the elements of what goes into designing a trial for Parkinson's disease. Um, and as anyone in clinical neurology will know, there are, relative to other neurodegenerative diseases, actually pretty good, even if partial symptomatic treatments for Parkinson's disease, typically most specifically the motor symptoms, although we keep refining those with new drugs coming on the market even this past week and this past couple of months with two new forms of levodopa, carbidopa, the subcutaneous or combination, now reflecting both those good treatments, but also highlighting what we haven't been able to achieve thus far, despite a lot of effort of trying to modify the disease, slowing its progression, and as I'll be covering now, the opportunity to try to actually prevent it. This review recently from Grace Crotty and our group highlights where we've been, and that most disease modification trials which are depicted in this timeline phase 3 trials here, it's little red circles you can see, have all been conducted, phase 2 and littler blue ones, after traditional diagnosis, generally as early as possible, but limited to that area. We typically have referred to them as disease modification trials, but as I'll try to highlight here, by going over the stages of Parkinson's disease, can be thought of as prevention studies in a tertiary prevention concept. So let me just lay out what is relatively new for us doing disease modification trials in Parkinson's. This concept that is very straightforward in medicine of depicting primary versus secondary versus tertiary, like the ones we've done so far. And in providing that framework, there's a medical framework that's pretty generic of what prevention is and how it can be broken into stages, but also hearkening outside of medicine to the ounce of prevention is worth a pound of cure adage, going back to primary reference here from Ben Franklin. He actually wrote on prevention of Parkinson, prevention of fires in an essay almost 300 years ago, and it makes for a nice metaphor that allows those in Parkinson's to be thinking earlier. Obviously, fire departments focus on fire engines and ladders. Actually, Ben Franklin coveted the Boston Fire Department at the time because he was making a pitch for improved prevention there. But he's really talking, of course, about tertiary prevention. He goes on to talk about trying to go earlier in the process when the fire is still in a controlled phase, as embers in these old Philadelphia houses that were prone to triggering these fires, but actually spends most of his essay talking about what would be primary prevention, which is before there's the process of the fire starts, but the risk factors. And back then it was creosote or soot in the chimneys, and which was an aggregation that in some poetic sense circles back to the aggregates in neurodegenerative disease that may be the focus of earlier stages of prevention. So that's where we've been with trials to date, focusing on what we call tertiary prevention. What I'll be going over is the advances that have allowed to shine the light earlier in the process prior to the traditional diagnosis, but after the start in what would be then considered secondary prevention. But before doing that, I have been in our work and conferences really focused on the clinical trial science that's now available to us in this earlier stage, and not really dwelling on what would be this ultimate prevention before the disease process even starts, partly because I don't think the science is quite there yet, but that hasn't kept colleagues from suggesting that prevention efforts really should be starting even earlier. This is an effort by Ray Dorsey, Todd Scherer, Michael Oken, and Bas Blom, who've tried to move the field towards prevention from a political or policy approach. And it's worth highlighting, I think, supported by their kind of efforts, that there's just been this past year landmark legislation of a national act to try to end Parkinson's, which includes trying to actually prevent it. Also worth noting in these anxiety-filled times that legislature can actually get something done, even though in this case the legislation has no money for it, but is a commitment to ending Parkinson's. Still, to get most Republicans and all Democrats to agree on something is a bit inspiring. So on this primary prevention notion, Ray and colleagues have highlighted what are in the list of modifiable risk factors known to be associated with, in this case, an increased risk of Parkinson's disease. This is from a paper where they make the case for actually a pandemic, given the rate of increase in Parkinson's disease in recent and coming years. That really is largely a demographic change, but they are focusing on reversible factors, and the idea that pesticides and the like that you may have read about in Camp Lejeune that have been implicated, although the proportion of Parkinson's disease that's contributed to by them may be very modest, but nevertheless sort of a noble aspiration to try to modify at an early stage the risk of the disease. It's worth noting that of the few things that they, in their speculative assessment, look at as modifiable risk factors, but given very little appropriately comment in the legislation or even in their book, is the association between smoking and Parkinson's disease. But as you may know, despite its strength across neurology, is probably probably the strongest neuroepidemiological link to anything other than aging and neurodegeneration. Smoking has been linked to not getting Parkinson's disease, which is obviously not a strategy for primary prevention, but it's interesting to note, as you may have heard, that in the UK, there's legislation being advanced to actually ban smoking gradually by anybody born after 2009 not being legally able to purchase cigarettes. And if that goes through gradually, there'll be a ban. And whether that will be also, in addition to being likely very helpful for the population, will increase the risk of Parkinson's, will be something that is a trial that I wouldn't want to design, but there may be data generated by that. More traditionally, that smoking clue has been pursued with the caveats that the causality is not clear, but there's some suggestive data that warranted the speculation by Ray and colleagues, and that's led to identification of the myriad components of cigarette smoke that may be protective from preclinical work. Nicotine has been advanced to the point where a phase 2 clinical trial over the course of a year, the NIC-PD trial, was just reported out as wholly negative for slowing down the disease in manifest disease, so not prevention. But that's raised the question of, if it is protective, what else in cigarette smoke might be protective? And this is just even if a digression on prevention, highlight a sort of that process of taking epidemiological clues back into the lab, as our colleague Steve Gompertz has done over at Mind, and as just reported, found somewhat heretically seeming, but rational for its potential, that low doses of carbon monoxide can actually can be protective in animal models of Parkinson's disease. This is from his group's paper led by Ken Rose, now Aileen Fisani, showing, just to give you some of the flavor of this, that with a drug that's from a company called Hillhurst, HBI-002, that can raise levels transiently after exposure to these rodents to levels about 10% of hemoglobin occupation by carbon monoxide, which is typical of a smoker, transiently, that in that setting, that in a unilateral model of synuclein toxicity delivered by a virus that can decimate the nigra that's shown here, that treating alongside with this carbon monoxide formulation can be protective of dopaminergic neurons, Th-positive neurons here as shown with the HbIO2, and similarly in the terminal fields, dopamine content that's lost with the synuclein is largely protected. And working with the company Hillhurst, Steve and I are now endeavoring to start a clinical trial, which is being supported by the Farmer Family Foundation and now the Fox Foundation, called Locomote PD, for low-dose liquid carbon monoxide, to evaluate its safety, tolerability, and pharmacokinetics and biomarkers in Parkinson's disease. With that, back onto prevention, what I want to focus on here for the remainder of the talk is the actual elements that go into a trial for secondary prevention of Parkinson's disease, and the insights on which that's based into genetics, biomarkers, prodromal features of the disease that have made the first trials for prevention possible and actually starting. Our department's taken a leading role for reasons that I'll highlight in a few minutes in trying to bring the community together over a series of conferences, now biannual, continuing the next one in 2026. But here bringing investigators, industry, regulators, at-risk advocates together to try to go over how to actually conduct these first prevention trials in Parkinson's disease. It's been a pleasure co-directing these with a former resident and fellow and faculty, Grace Crotty, before she moved to Ireland and Cork. But we're still teaming up to conduct these studies. So in addition to why it's now a good time to be finally pursuing prevention, we try to kind of parse out the elements of designing prevention trials, focusing on who's at risk, at high risk in particular, how to measure prevention, progression prior traditional diagnosis, and also what to test, as well as bringing together this community. So the principle should already be clear from Ben Franklin's perspective. The precedent for this really has some positive and negative features. This slide from Alberto Espe depicts rather harshly the cradle to grave trajectory that has been so far for Parkinson's disease, the result of efforts to try to conduct disease modification for tertiary prevention in Parkinson's. Even since this slide was put together, there have been some more laying to rest. And just a couple of weeks ago, you may have heard that the hopefulness of a phase 2 data from GLP-1 agonists was kind of undercut by phase 3 trial results showing no benefit of exenatide. So here, I'm very briefly going to go into a story that was the motivation for ultimately with the results of a rational trajectory for targeting disease-modifying therapy and elevating urate in Parkinson's disease as a inverse risk factor for the disease. And our group, working with Alberto, whom I mentioned, has tried to understand these relatively poorly studied inverse associations that are arguably more important as an epidemiological risk factors than positive risk factors, because they're telling us something about who doesn't get the disease. And actually in Parkinson's, these inverse risk factors are fairly robust. I've already mentioned smoking. And in the case of urate, it's combined with other evidence, evolutionary neurobiological evidence that has led to a therapeutic approach. In the lab, I won't go over the results, but I'll just highlight that over the years, after the epidemiological links were laid clear, Shi-Chuan Chen in our group, now associate professor and leading her own group, had highlighted the protective potential of elevating urate, and now actually has turned to another epidemiological clue in clarifying at a preclinical level the potential mechanism of how melanoma is a risk factor for the disease, and gone on to extend that to cancer more broadly in its relationship to Parkinson's disease with her ongoing program. And then similarly, just in the shout out vein, in our group, Assistant Professor Rachid Bakshi has also focused on not only urate, but a range of implicated inverse risk factors for the disease, together with newly minted instructor Ning Xie, who's studying these factors back in the lab to see what's warranted to advance into the clinic. Another collaboration that I'm delighted to highlight as a reflection of sort of the family approach here and collaboration across disciplines, working with the Parkinson Study Group that I've had the honor of leading for the past 12 years, but was started over 30 years ago around the DataTop trial, and with Stan Fahn and Ira Scholson, who sadly passed this year, reflecting, well, not his passing, but his spirit, reflecting the collaboration that brought our many groups into Parkinson's disease and allowed data sharing for this particular urate example. That's also reflected by others, and just pointing out this, as some of you who may have attended the funeral service by Zoom of Warren Allenow, note that there are many who just passed this week suddenly. Note that we are building this progress on many colleagues' contributions. So again, briefly, it was going back from Alberto's observations of the strong link between urate blood levels in epidemiological cohorts to reduce risk of the disease, working with Ira's help and several trials like the original DataTop trial and Precept to see whether this association with reduced risk was also associated with a different rate of progression. So piggybacking onto the data and the urate levels that were available in blood and spinal fluid from those patients in those studies who were, as is customary, as I pointed out, typically in disease modification trials, caught as early as possible, so just after diagnosis and not yet on treatment, so-called de novo patients, and the rates of progression in multiple studies were very robustly matching what was seen in the epidemiological cohorts, showing that people who had higher levels of urate had a slower rate of progression. That led to not only the preclinical and early clinical studies, but to a fairly definitive phase 3 trial called SurePD3 for studying urate elevation in Parkinson's, in which we had demonstrated target engagement, if you will, to the extent that, as shown here, the serum urate levels could be substantially and sustained in their elevation for years. But at the end of that study, with the reversible urate elevation, what was observed was no difference in the rate of progression by multiple clinical measures or by biomarkers available at the time, serial DAT imaging showing no separation between the precursor to urate, inosine, which elevated it so clearly, and the placebo group. This is just another shout out to my colleague now in our department, Eric Macklin, who's the lead statistician, not only for this and other Parkinson study group studies, but also the Healy, one of the leads in the Healy Center, and a great contributor. So with that clear, this might lead one to think, with our own personal example, sort of etched in limbic lobe of another negative trial, that this sort of approach may be the definition of insanity, just because we haven't had success, at least in our corner of neurodegeneration, and modest overall. But push back heavily on that notion, because it's very clear that over the course of these tombstones, we have, even if incrementally and maybe more recently by leaps, improved the way we design trials, the way we select candidates. It's worth noting that particularly hopeful next set of disease modification targets really differ from the prior efforts in almost exclusively focusing on gene-driven clues, whether it's synuclein, LRRK2, or GBA, Parkinson's, and those trials are ongoing. So the precedent that I mentioned is negative, that driving us towards focusing on prevention with caveats because of the progress. There's also clearly positive precedent too, with being able to go into prevention and address this sort of obvious but meaningful metaphor of trying to go earlier before the horse is out of the barn. There's certainly precedents from outside of neurology with the recent FDA approval of moving for the first time from symptomatic therapy for diabetes to a form of prevention based on staging of the disease. And there's precedents and opportunities to learn from across neurodegenerative disease, where really all neurodegenerative diseases are now taking advantage of opportunities to move earlier in the process. Huntington's and Alzheimer's here are next to Parkinson's, but even in ALS, trials are starting, like the Atlas study, to try to move earlier, often with genetically identified but otherwise prodromally identified people at risk for these diseases. The idea of who, what to target, what to test, how to measure it are challenges across neurodegeneration. And it's the answers are obviously somewhat different across the diseases. Who to target, and Huntington's, of course, is driven genetically. Alzheimer's has had the advantage of biomarkers for how to measure and the like. This is just reflecting the couple steps we are behind Alzheimer's disease, at least in the potential of designing these trials and staging the disease prior to the traditional dementia definition. Even if you consider MCI to be prodromal, it's really the biomarkers that are defined by beta amyloid and tau that allow for really moving from tertiary prevention towards secondary and primary. So that's why, with the addition that we now can in Parkinson's, because we've made so much progress in recent years, particularly on identifying who is at risk for the disease. And that's somewhat heterogeneous in the case of Parkinson's, because there are both folks who are clearly now appreciated to be at increased risk genetically, even if not with the penetrance of Huntington, but also and more actionably for now, a prodromal picture of Parkinson's disease, which, unlike the prodromal picture for Alzheimer's, is not just milder main cognitive symptoms, but really quite distinct prodromal features, clinical features that precede, often by years, the motor features. And this is just a sort of a timeline view of from a decade or so back, how one might think of the diagnosis starting here, with obviously appreciation that there has been a insidious progression of some motor symptoms starting a few years typically before, and then from pathology and imaging, it being pretty clear that the process has been going on for some time, but really with a very vague description of what that is. So we were kind of left with the classical movement disorder features based on the pathology of losing dopaminergic neurons in people who have Parkinson's disease. But it's that elucidation of what comes before that has been so impactful, and that is the prodrome for the disease. The semantics are evolving, and it's still, I think, useful for those who focus in the patient community as well on the definition still around the motor features that the prodromal comes before a traditional diagnosis. And that can be broken into sort of different phases. Obviously, prior to a diagnosis, the motor features are building and their early features, but premotor, non-motor features often precede that. The early motor features, it's worth parsing out the different stages of this prodromal phase when secondary prevention can be applied, because how one targets these different substages will depend on where they are in the pathophysiology. So obviously, quantitative motor markers, DAT changes are particularly sensitive in that early period. Prior to that, as I've been alluding to, in the premotor prodromal clinical features, there's a constellation of them as you probably know the prototype of prodromal features is REM sleep behavior disorder. Hyposmia is right behind it, although not with quite the impressive specificity, such that following cohorts of REM sleep behavior disorder patients has shown that within about a decade or so, about half will go on to develop a diagnosis of synucleinopathy, not just Parkinson's disease, but dementia with Lewy bodies prominent as well. And that rate of phenoconversion is also, of course, influenced by whether there are other features like hyposmia or constipation and other prodromal features. One step earlier in what can still be considered a prodrome is prior to any clinical features or preclinical stage has been afforded by what really is a breakthrough in the field in the last couple of years of identifying pathological forms of alpha-synuclein as can be assayed by its aggregation propensity with a SAA seed amplification assay for alpha-synuclein, best worked out in the spinal fluid, but also now comparably in skin biopsies, showing the diagnostic accuracy that has been demonstrated sort of convergently with the work of the Fox Foundation's PPMI, Parkinson's Progression Marker Initiative, in this landmark study from Andrew Sidoroff and colleagues in the group that showed comparing to healthy controls, the relatively few people who have positive seed amplification compared to the sensitivity in this large prospective, really this was a cross-sectional study here comparing to Parkinson's patients who had their CSF taken early in the disease, where close to 90% were positive. But that, if you look a little closer at the subgroups within those with Parkinson's disease and their positivity, it actually approached 100% if you also included those who are hyposmic or those who had sporadic Parkinson's disease as opposed to genetic forms. And that's because, and that includes GBA Parkinson's, which was similarly highly positive for seed amplification assay. There are a couple of informative and still puzzling exceptions where at least the LRRK2 subset of genetically associated Parkinson's disease actually has a significantly smaller proportion of positivity, which brought down the overall average, but still a major advance in the identifying the biological process, arguably after the disease has started, but before even clinical symptoms are manifest. This just shows in a sub cohort of the PPMI study, the RBD patients who were looked at here by their x-axis sense of smell, y-axis their DAT imaging. And you can see that most RBD patients are already positive for this seed assay, particularly if you exclude those who are not hyposmic. But even those who do not have a low DAT binding score, who have not lost much dopamine transporter, even those folks who are synuclein positive for the who are hyposmic, who have RBD, suggesting that this process can be of the disease can be identified even prior to its clinical manifestations. So again, if these colored lines to the right represent clinical development of features and even DAT loss associated with the motor features, there's evidence now of the biological process being identifiable earlier with prodromal features. And this is very much akin and again modeled off of what is taking place, has been over the past decade in Alzheimer's disease, where the amyloid tau imaging, but also biofluid measurements increasingly can allow for staging the disease and the design of trials. This led the PPMI group, led by Tanya Samuni and colleagues, to make the case for developing an integrated staging system, an ISS. Semantically, it's been a little controversial. It's not labeled for Parkinson's disease or Lewy body disorders, but terminology that's been focused on is neuronal synuclein disease to distinguish it from MSA, is a glial synuclein disease. The semantics and the actual definitions is really a source of debate, but it's really much more a source of hopefulness in with everyone acknowledging that this is a research framework, but also that allowing us to define the disease biologically and to begin to look at stages at an early stage, which is reflected in their staging scheme, really will increase the likelihood that prevention trials will be successful. So the staging here, as they've outlined it, is based on biomarkers, alpha-synuclein, and DAT measurements, DAT imaging typically with clinical features to follow. Then, in addition to who is at high risk that can be enrolled in these trials, a lot of the effort and really the biggest unanswered questions have focused on what to actually measure prior to diagnosis. As you may know, if you've worked on clinical trials for disease modification progression after diagnosis, it's already hard enough with symptomatic therapies markedly affecting what you measure clinically, but it's even harder when symptoms are subtler prior to traditional diagnosis and more varied if you're relying on multiple non-motor features. That is actually the main area, as reflected, as I'll show just a minute, in sort of the current landscape of the initial trials, still all over the road for what people are trying to measure as trying to settle on something that's reliable. Obviously, the most reliable measure would be conversion to synucleinopathy, Parkinson's, or DLB. But of course, even with an RBD-enriched population, that can take, as I mentioned, years, a decade. And although that can be plausible, if you enrich further, the field is very much looking for tractable biomarkers or clinical digital biomarkers that may be stage dependent, where what one will look for in the stage 3 NSD-ISS classification may be very different from earlier. And then I just wanted to touch on, what it is that is being tested. It's, largely informed by what is thought to be at play in driving the disease after it's manifest, although it can differ at different stages. So tailoring it to the stage is important, but also another principle rationally is a focus, even greater focus on safety, given that people who are at risk for disease may not yet have any symptoms or any disability. And so the therapeutic index has to be kept in mind. Right. And this is just back to that metaphor of considering that now as we're moving earlier, what to test may very much if you take the metaphor to ground of closing the barn doors prior to disease diagnosis, that intervention may be very different from doors from a lasso, which is probably overstates the pathophysiological shift as the horse gets out of the barn, but does illustrate that that's an important principle to consider as well. Again, safety has led to a suggestion, us and others, of taking advantages of candidates that may be implicated, but more a higher, greater safety. But it also, again, focused generally more on genetic clues. Industry-driven compounds that are focused on genetics have also been the focus of what is one of the most rapidly maturing platforms, modeled a bit after the Healy platform trials of the Parkinson Fox Foundation's PPMI initiative platform trial called Path to Prevention, which is a early stage efficacy study focused around prevention or secondary prevention, built around this staging framework. It's building off of the vast global PPMI network that's been characterizing these biomarkers, including here led by Alex Videnovich in our movement disorders group, that from which may be recruited patients in the next couple of years of for these first prevention trials. So this is sort of a busy slide, but it just reflects this year at our conference how we put together or highlighted a couple studies that have actually already started for prevention and a couple that have been committed to. Let's see. This is the PPMI Path to Prevention platform that I just mentioned, for which, and then Slow Speed is an app-based exercise intervention trial. A trial started actually already a couple of years ago with a mitochondrial repurposed drug, idebenone, in Shanghai, and then one that's about to start at Yale under Jesse Cedarbaum, targeting a immunomodulation with Humira, TNF alpha blocker. They all pretty much have anchored around RBD with hyposmia, but genetic studies are being planned as well, including for an arm in the Dutch slow speed study is where that exercise intervention is starting, but there's plans to move to the UK and then the US with 23andMe targeting genetic forms. I've already mentioned here the relatively wide range of early targets amongst that list that I highlighted, and certainly many others. And then again, reflecting probably the biggest challenge is what to measure, ranging from the obvious but challenging phenoconversion to DAT imaging changes, classical motor symptom changes, other imaging changes are being considered. So lastly, I just wanted to highlight that this endeavor where we're trying to build a community and learn from each other in sort of a pre-competitive space with this educational series, importantly has brought together a community that hasn't really self-assembled very much as yet, which unlike the advocacy communities of Parkinson's or ALS, the typical ones, comprise people who are at risk for the disease. And so it's been important to bring their voices in as well, and they've been prominent in guiding our efforts, and similarly reflected here by the highlighted people who are either genetically or prodromally at risk, or have been guiding us in highlighting key issues, including some of the ethics, which I already alluded to, where folks who don't necessarily have a disease, let alone a disability, may be having to consider diagnostic information that tells them that they're at high risk, and how the ethics of that are critical to address early in this process. And similarly, what types of interventions make the most sense. It's great to be guided collectively. So back to the family I had alluded to with the department family and my own and the mashup. This is just a reflection of our dogs. No relation to Charlie, but Charlie Sherpity, who's now passed, was the mascot, got a bone every time in a phase 2 study for SurePD. Someone enrolled around the country. And of course, it took like 2 years. So we went through probably 2 Halloweens for his cycle during the recruitment period. And now Charlie's replacement, Bindi, working on the Sparks-3 exercise trial, not as sharp as Bindi's posture here would suggest in terms of his brightness, but he is a motivating factor there. So I just wanted to highlight that as well. I see that there's time for questions, so that's good. And I won't dwell on it, but I'll just highlight that we're actually looking at caffeine and adenosine A2A receptors as a candidate for prevention that we are pursuing. And I'm just doing this to show you that there's some biology I'm happy to go over, and also the exercise initiative of Bas Bloem's group that Eric and Alberto and I are contributing to is also in the throes of a prevention trial. So just as some examples, but I'd be happy to answer any questions that come up. So thank you. Hi, Maren. I'm sorry you missed your earlier images from 30 years ago. Part of the family
Sorry, I
spirit.
missed it too. First of all, just fantastic work and leadership of this community, bringing them together. I was wondering your thoughts on people getting some of these synuclein tests. Are you getting those type of questions? And given that maybe we don't know what to do about it yet, what's your general approach on that?
Yeah. So the efforts to commercialize tests. Right now, it's a period where the field is saying this is the time to figure it out. Because right now, the available tests are on CSF and skin biopsy. So there's people aren't knocking down the door. But when it's sort of at the cap, the aisle at CVS to get a home saliva test or blood test, which is although I highlighted the progress here on those less accessible but in life assays. Uh, there's a lot of excitement and some progress on those kinds of assays. So yeah, figuring that out is going to be important, and it won't just be you know uh, neurologists, but primary care physicians, and then even direct to consumers. So I don't have a good answer except to say that this is the time to be figuring it out, and I'm sure it cuts across. Obviously, I think it's most active in Alzheimer's right now because blood tests are available.
Mike, really nice to see the whole sort of arc there. I'm interested in the clinical staging because they really do seem to align with the pathology, Brock, brainstem gradual progression. Are there studies yet based on, I mean, there may not be enough people who've come to autopsy, but even retrospective looking through autopsy series to see whether those do correspond accurately to the Brock levels, medullary pontine and midbrain as you move up before you come to your motor symptoms?
Yeah, I think that's a great question. And I think there are efforts to try to refine the pathological matching of that. It doesn't seem perfect, but I don't know how systematically it's been done. I think there's a larger effort now to look at in life at these assays, and instead of just these cross-sectional studies, but to actually follow these cohorts from RBD, or even if you can screen and get positive folks, and then before they get clinical features. And so I think that is going to be a big challenge and opportunity.
Mike, I was interested in your paper that actually talked to people who who are considered preclinical or looking at patients' inputs. And that's been such a huge force, for instance, in AIDS research. As soon as there was a test that could identify people who were still healthy but might get AIDS, they became this huge advocacy group. And the same thing is kind of happening in Alzheimer's as well with the ApoE4 allele. And I'm wondering if you could talk a little bit more about that paper. Is there an organized group of preclinical Parkinson's people? Are they interacting in any way with some of these other advocacy groups? I'm just interested in the public health aspect of it, I think.
Yeah, I think it's somewhat organic and early now. There are a handful of people who have taken this cause on, started websites and the like. Our conference has been a starting point as well, reflecting that advocacy. Parkinson's is never going to be like AIDS and ACT UP. Part of it is pre-baked into the pre-morbid personality, perhaps, of Parkinson's patients who are not going to yell as much at their doctors and researchers to get this right. Nevertheless, as an example of efforts, we're doing this biannually now, this conference, and we are just had a call yesterday with the World Parkinson's Congress leadership to piggyback to the Arizona triennial World Parkinson Congress to actually try to cultivate some of that exact spirit. So I think on our part as researchers, we have to make a seat at the table and work early on, and whether it's putting together papers or helping start initiatives, that's on us too.
Mike.
Mike, thanks for all these comments. So sitting atop the PSG, you have really unique and broad perspective on the preclinical pipelines that went into all these various studies that ultimately went to human trial. And such feedback. But from that tombstone slide, all of those trials had, presumably all of them, had some strong animal model data showing efficacy. So it seems evident that our preclinical models aren't sufficient, at least, to predict whether it's going to work in humans. What keeps me up at night is, do you think they're even necessary? In other words, do you think we understand the underlying biology well enough that failure in these preclinical models predicts failure in humans? And how many ideas that are inspired by, say, human data, human genetics, that are then rooted out and fail in the lab could have been successful in humans because we're just not even capturing the critical biology in animal models? And how do we think about screening things out? And should we be maybe more liberal by bringing things to clinical trial?
Yeah, no, it's a great question. The dogma of like the central dogma of starting with whatever the clue is, taken in the mice or some model, and then into the clinic is one that we have less security over now than we did before. I think a nuanced and rational approach to that uncertainty for me over the years, despite having a lab preclinically, I overall put less stock in, but I think the more nuanced approach is to ask where the target is coming from. And you alluded to it before. If it's a genetic, if it's strong causality that's implicated by just the genetics, so then clearly there's less of reliance. And in fact, some of those most promising studies have very little animal data, like the GBA and LRRK2 targets. Both of them have made even lousier preclinical models in vivo. So they really haven't relied on it, and no one has a problem with that. I think if you're working on neurotrophic factors, for example, where there's really no genetic or epidemiological, no numal tie, just sort of a theoretical thing, then you have a higher burden to prove. But it's still usually a useful thing. And one other note I just remember, historically, it used to be the standard, you had to have primate data because, primates are closer to us. And by trials that had primate data not having any signal, and all these other more holistic considerations being taken up, I think there's no requirement. It doesn't have to be a synuclein model, it doesn't have to be MPTB, it doesn't have to even be a model in some circumstances. Oh, but if I may, just to point out from this vantage of the PSG, I happily, after 12 years, have turned over the reins. Andrew Sidoroff and Juhi Jimenez Shahed have been elected to now lead the organization. So now I'm with the rank and file and enjoying this progress.
Mike, that was great. Chasing biomarkers is something that we do all the time. In epilepsy, if we see interictal spikes on the EEG, we can make that biomarker go away by disconnecting the machine. Plaques and tangles were discovered 120 years ago, and we're still chasing that. And I think your example with urate, is a well-designed, trial based on a great observation. But how have you? I know you've thought about this a lot, but how far up the causal chain do you need to go from the biomarker that's correlated with the disease to find the place where causality branches, and this causes Parkinson's and an increase in urate? So
yeah, it's a great question. The term biomarker, which as an anchor, is extremely valuable when the final distal, even uncertain target is a unwieldy clinical phenomena. But biomarker is also a very complex term. Not only the different types, but for the pathophysiology, that one type, you can be proximal or distal. So in our case, urate, I almost say it with a caveat when I say we had target engagement with a biomarker. Urate, we gave inosine. In our case, since we were driven by the genetic, largely by the epidemiology, we had target engagement. So we just wanted to elevate urate, and we want to do it in the CNS. But that's fairly proximal in any hypothetical chain to neurodegeneration. Synuclein as a biomarker, which has again been the focus of a lot of enthusiasm, is clearly close to it. Some argue, and I didn't get into the debate so much, that an alternative view is not to focus on synuclein, or not to focus on DAT imaging. There's this whole competitive Tony Lang's alternative approach. So synuclein is a good example of something from the genetics to the biology that is likely distal, but even there's some uncertainty. So I think it's good to look at what the biomarker is when you say you have a biomarker to show that it's working, and how close it is to disease. Urate is actually pretty far away, even though it's downstream of the drug that we gave, which was inosine. Well, thank you again, and happy Halloween.